Okay, imagine stepping into a hospital maybe after a burn injury. It's a really stressful time, right? Confusing. And suddenly you're hearing all these medical words flying around.
Yeah, it can feel like a totally different language.
Exactly. And whether you're the patient or maybe a worried family member or even a caregiver, just trying to understand what everyone's saying can feel, well, overwhelming.
Hmm.
So today, we want to be your guides. We're going to walk through some of the really important terms you might hear in burn care.
The goal is to help you feel more informed and hopefully, a bit less overwhelmed by it all.
Right. We're going to unpack three key areas today. First up is total body surface area, or you'll hear it called TBSA.
TBSA, yeah.
It's a really crucial measure, and we'll explain exactly what that means. Then we'll dive into the different degrees of burns, or maybe depths is a better word.
Depths, yes. That tells you how severe the injury is.
We'll help you understand that, maybe even just by how it looks. And finally, we'll tackle skin grafts. Specifically, what's the difference between an autograft, that's skin from you,
Ago means self.
and an allograft, which
Yeah.
is skin from someone else?
And look, this isn't just about learning complicated medical jargon, is it?
No, not at all.
What's really important here, I think, is that knowing this stuff actually helps you feel more in control,
Well,
especially in a situation that feels very out of control. It
mhm.
clears up confusion and it empowers you,
Yeah.
really, to ask better questions. You can participate more in the care,
Yeah, build a clearer picture.
exactly, a clearer picture of the road ahead, the path to healing, kind of piece by piece.
Okay, let's do it. So let's start with that first one. Total body surface area, TBSA.
TBSA.
So, put simply, TBSA just tells us how much of your body's skin has actually been affected by the burn.
Right.
Think of your skin like a big map. TBSA is basically the percentage of that map that's been burned.
That's a great analogy. Like, if a quarter of the map was colored red, that's 25%. Gives you a sense of scale.
Exactly.
And clinicians, they have some pretty clever ways to estimate this percentage, often quite quickly. For adults, a common method is called the rule of nines.
The rule of nines.
Yeah, it's a rapid way to sort of assign percentages to different body parts. So, for instance, each arm is considered roughly 9% of the body's surface.
Okay,
Each leg, being bigger, is about 18%. That's like two nines.
gotcha.
The front of your torso is 18%. The back is also 18%. And then the head and neck together make up another 9%.
That adds up.
It does, roughly. But it's worth keeping in mind that for kids, it's different. Their body proportions change a lot as they grow.
Right, their heads are bigger proportionally.
Exactly. So doctors use different charts for kids, like the London Browder chart.
Yeah.
It's more detailed, gives a more accurate picture for children.
And here's a little trick, actually, that doctors sometimes use. It's surprisingly practical. For adults, they can quickly estimate that the size of the patient's own hand, palm, and fingers together is roughly 1% of their total body surface area.
Oh, interesting. The patient's hand, not the doctor's hand.
Right, the patient's hand is 1%. It's apparently a really handy tool, especially if the burn has kind of weird, irregular shapes.
That makes sense. It's definitely a valuable shortcut for a quick look. Now, here's a really crucial point to understand about TBSA.
Okay.
Those very mild burns, the ones we call first-degree burns, like a typical sunburn, they generally are not included in the TBSA calculation.
Ah, okay, so they don't count towards that big number.
No, usually not. They're just not considered severe enough to factor into that critical percentage that guides the really intensive treatments.
Okay, so understanding what TBSA is makes sense. But the really big question for doctors and for you listening is, why is this number so important? What does it actually tell them?
Yeah, connecting it to the big picture, TBSA is hugely important. It's the main thing doctors use to figure out the overall severity of the burn injury.
Right. Severity.
But maybe even more critically, it helps them calculate exactly how much fluid a patient needs, usually through an IV.
Ah, the fluids. Okay.
Exactly. It's called fluid resuscitation. And this fluid is absolutely essential to keep the patient hydrated and stable, especially in those first really critical 24 to 48 hours after the injury.
Wow, okay.
So, for example, you might hear that a minor burn is less than 10% PBSA. But if an adult has a burn over, say, 20% TBSA, that's usually considered a major burn.
And that changes things
Yeah,
significantly.
absolutely. A high percentage like that often means an immediate transfer to a specialized burn center. They just have the resources and the specific expertise for that level of intensive care.
That really shows how much every percentage point counts.
Okay, let's shift gears now to something that can also cause a lot of confusion. burn depths. You often hear degrees of burns, right?
Degrees or depth.
To help kind of picture this, think of your skin like a cake, maybe a two-layer cake.
Okay, I like cake.
The really thin top layer, the part you see and touch, that's the epidermis.
Epidermis, got it. And then underneath that, there's a thicker layer called the dermis.
Dermis, okay.
So burn injuries are basically described by how deep they go into these layers, or sometimes even deeper.
That cake analogy is perfect, actually. So let's start with the mildest type, the first-degree burns.
Okay.
These are also called superficial burns because they only hit that very top layer, the epidermis.
Like a sunburn.
Exactly like a common sunburn. The skin looks red. It might feel warm, definitely painful on the surface, but crucially, it won't blister or break open.
And the healing.
The good news is they usually heal pretty quickly, maybe 3 to 5 days. And they don't leave a scar because the deeper skin layers aren't really damaged.
Okay, that's first degree. Then we get into second degree burns, also called partial thickness.
That's right. Partial thickness, these go a bit deeper. They damage both the epidermis, that top layer, and then varying amounts of the dermis underneath.
And these are the ones that blister.
Yes. Typically quite painful. They often swell up, and they will form blisters. And actually, within this second-degree category, there are 2 important subtypes to know about.
Okay, 2 types of second degree. What are they?
Well, first, you have superficial partial thickness, second-degree burns.
Okay.
These are still very painful, usually look quite moist, maybe bright red. But because they only damage the very top part of that second layer, the dermis, they tend to heal relatively faster, usually around 2 weeks or so.
And scarring.
Generally, they don't leave a permanent scar. But then the other type is deep partial thickness second-degree burns.
Okay, deep partial. Sounds worse.
It is. These injuries go much deeper into that dermis layer, so they take longer to heal, and they usually do result in some scarring. Often they need surgery, like a skin graft, to get the best healing outcome.
Right. Now, you mentioned something interesting earlier about pain.
Yes. This is what's really surprising and can be, frankly, unsettling for families. These deep partial thickness burns might actually be less painful than the more superficial ones.
Less pain for a deeper burn? How does that work?
It's a strange paradox, isn't it? Deeper injury, sometimes less pain right there at the site. It happens because some of those tiny pain receptors, the nerve endings in the skin, have actually been damaged or destroyed by the heat going deeper.
Wow.
These burns can look different too. They might appear drier, maybe a mottled red and white color, or have kind of a waxy look compared to the really moist, bright red of the superficial ones.
So it really highlights that you can't judge the severity just by how much it hurts.
Absolutely not. Understanding the depth, not just the pain level, is critical for getting the right diagnosis and the right treatment plan.
That's a really crucial takeaway. Okay, moving on to the even more serious categories, let's talk about third-degree burns.
Right. These are also known as full-thickness burns. Very serious injuries. They go through all the layers of skin, the epidermis, and the entire dermis.
All the way through the skin.
Yes, and they can even affect the deeper tissues underneath, like fat or sometimes even muscle.
What do they look like?
They often look charred. Or they can appear sort of leathery, maybe black or white, or a deep waxy red. And here's another surprising detail.
Okay.
The injured area might feel numb, like numb to light touch or even pressure.
Numb. Again, that seems counterintuitive.
It does, but it's for the same reason as before, only more so. The nerve endings in that whole area have been completely destroyed by the intense heat.
And healing.
This is critical. Third-degree burns do not heal on their own. All the skin cells that would normally regrow skin are gone. They almost always require skin grafts to close the wound.
Always need surgery. Okay. And then beyond third degrees, sometimes you hear about even deeper burns.
Yes, though less common, thankfully. Fourth degree and deeper burns. These are the most severe imaginable.
What do they involve?
They don't just destroy the skin. They extend deep into the underlying fat, muscle, and sometimes even penetrate right down to the bone.
Oh.
The affected area often looks completely blackened, charred. And tragically, these kinds of burns can sometimes lead to the loss of that body part because the tissue damage is just too extensive.
And the pain level there.
Similar to third-degree burns, there might be no pain right in the burned area itself because of that complete nerve destruction, which, as you said, can be incredibly confusing and honestly quite alarming for patients and their families.
Definitely. So, okay, we've looked at the extent of the burn with TBSA and the depth with the burn degrees. Now, the logical next step is, how do doctors fix the deeper injuries? Which brings us to skin grafts.
Skin grafts.
So just generally, what are they?
In basic terms, skin grafts are thin layers of healthy skin. Surgeons carefully take this skin from an unburned part of the body. That place is called the donor site.
The donor site.
And then they precisely move that piece of skin to cover the burned area. The goal is to help it heal permanently.
Got it. And you mentioned two main types earlier, autografts and allografts.
Exactly. Let's start with autografts. Remember, auto means from you.
So, skin from the patient's own body.
Correct. An autograft uses the patient's own healthy skin. And this is really considered the gold standard in burn care.
Why the gold standard?
Because it's your own skin. Your body recognizes it, accepts it completely. It integrates and provides a permanent living solution for replacing that damaged skin.
Okay, so your own skin is definitely the best bet for a permanent fix. Are there different kinds of autografts they might take?
Yes, good question. Mostly they use what's called a split thickness graft.
Split thickness.
Yeah. They use a special instrument to carefully shave off the epidermis, that top layer, and only a very shallow part of the dermis underneath.
Why only part of the dermis?
That allows the donor site, the place they took the skin from, to heal on its own, kind of like a scrape or a superficial second-degree burn. It usually heals in about 2 weeks.
Ah, clever. Are there other types?
Sometimes. For smaller areas, places where appearance is really critical, like the face or hands, they might use a full-thickness graft. That takes the epidermis and the entire dermis layer. It gives a better cosmetic result sometimes, but the donor site needs more help to heal, maybe even another graft.
Okay. So, the huge benefit of an autograft is that it's permanent because it's your own tissue.
Exactly. Your immune system says, yep, this belongs here. It integrates, gets blood supply, becomes part of you. That's the ultimate goal for burn reconstruction, permanent closure with your own skin.
But there have to be downsides, right? If it's so good, why isn't it always used immediately for every burn?
That's a really important point. The biggest limitation, especially with very large burns, is pretty simple. You only have so much unburned, healthy skin available to use as donor sites.
Right, if someone has burns covering, say, 50% of their body.
Exactly. Where do you get enough healthy skin to cover that 50%? It becomes a major challenge. Plus, remember, taking the skin for the autograft creates another wound, the donor site itself.
True. That donor site needs to heal too.
Right, usually takes about 2 weeks. And managing those donor site wounds adds to the overall burden of care. For kids, it can be even tougher because they're smaller, less skin available overall.
Okay. And sometimes you hear doctors talking about meshed grafts versus sheet grafts. What's the difference there?
Yes, meshing. So a meshed graft is where the surgeon takes that piece of donor skin and puts tiny, precise slits in it using a special machine.
Slits? Why?
It allows the skin to be stretched out, almost like expanding a net or a mesh. Think of it like a chain link fence pattern. This lets a smaller piece of donor skin cover a much larger burned area.
Oh, that's smart. So you can make the donor skin go further.
Exactly.
Yeah.
It's incredibly useful for covering very large burns efficiently when donor skin is limited. The downside is it might leave a slightly noticeable grid-like pattern on the skin long term.
Okay. And a sheet graft.
A sheet graft is just what it sounds like, a solid, unmeshed piece of donor skin. It's used directly.
When would they use that?
These are usually preferred for smaller burns, or in areas where the final appearance and smooth function are really critical. Think face, hands, maybe over joints. They generally give a smoother, more natural-looking result.
Got it. That makes the different approaches clearer. Okay, now let's move to the other main type, allografts. Allo means
From another. So these grafts come from another person, a human donor.
another person. Like who?
Often, it's skin generously donated by someone who has passed away, similar to organ donation. It's sometimes called cadaver skin. In very specific and much rarer situations, it might even come from a healthy living relative, like maybe a parent donating to their child.
Okay. And the key thing about allografts is
The absolutely crucial thing to understand is that allografts are temporary. They are not a permanent fit.
temporary. Okay, so if they're only temporary and the body's going to reject them eventually, why use them at all? It seems like extra steps.
That's a great question. But allografts play a really vital, often life-saving role. Think of them as a bridge.
A bridge.
Yeah, a bridge to permanent grafting. They fill a critical gap when a patient, maybe someone with really extensive burns, just doesn't have enough healthy skin right now for an autograft.
Okay. Or maybe they're too sick for another big surgery.
Exactly. Or if the patient is too unstable, too critically ill in those early days for a long autografting operation. The allograft acts like a biological dressing.
A biological dressing, what does that do?
It does several really important things. It covers the large open wound, which immediately helps protect it from infection. It dramatically reduces pain, because it covers those exposed nerve endings.
Ah, pain reduction. That's huge.
It really is. And it also helps prepare the wound bed underneath. It keeps it clean and moist, gets it healthier, essentially getting it ready for the patient's own skin, the autograft, which can be placed later when the patient is stronger or more donor sites are available.
So how long do these temporary allografts usually last?
Typically, they stay on and function for about, 2 to 3 weeks.
Hmm.
After that, the patient's immune system starts to recognize the allograft as foreign tissue and begins to reject it.
Rejection sounds bad, but it's expected here.
It's totally normal and expected.
Hmm.
It's just the body's natural defense mechanism kicking in. There was actually a case described, I think, of a 5-year-old girl with really extensive burns. She received a temporary allograft from her father,
Wow.
and that graft served as that vital biological dressing, protecting her wounds, helping control infection, reducing her pain, allowing her to stabilize before her body eventually, naturally rejected it. Then she was ready for her own autografts.
That really illustrates their role as that bridge. So, summing up allograft's main benefits and any drawback.
Okay, benefits.
Uh-huh.
They're relatively cost-effective compared to some artificial skin substitutes. Big ones are reducing pain and controlling infection. They also cut down on the need for frequent, really painful dressing changes over large areas.
Okay. And the downsides.
The main drawbacks are availability. They depend on human donation. And there's always a very, very small theoretical risk of disease transmission, although donors are incredibly carefully screened to minimize this risk.
Makes sense. And you mentioned fresh allografts.
Yeah, sometimes fresh, meaning recently harvested and not frozen. Allografts might take or adhere to the wound a bit better initially, but both fresh and frozen are used effectively.
Okay. Wow. We have covered a lot of really important ground today. Let's just quickly recap for everyone listening.
Good idea.
We've tried to demystify some of those terms that can feel pretty intimidating in a hospital. We unpacked total body surface area, or TBSA, that percentage, telling us how much skin is burned and why it's so crucial for planning treatment, especially fluids.
Right. The rule of nines for adults, Lund and Browder for kids.
Then we explored the different degrees or depths of burns, from the red, non-blistering first degree
Like
to
sunbursts.
the blistering second degree, remembering their superficial and deep partial thickness, and that deeper doesn't always mean more pain initially.
That key paradox, yeah.
Then the serious third-degree full-thickness burns that destroy all skin layers and often feel numb.
And always need grafting.
And the most severe fourth-degree burns going down to muscle or bone. And finally, we tackled skin grafts, the permanent gold standard autografts using your own skin,
Meshed or sheet.
and the temporary but vital allografts from a donor, acting as that biological dressing, that bridge to healing.
And just to reinforce, learning this stuff isn't just about knowing the medical words.
No.
It's really about empowering you, helping you understand what's actually happening to your body or your loved one's body.
Yeah.
It helps you know what questions to ask the doctors and nurses.
To be part of the conversation.
Exactly. To feel like an informed partner in the whole recovery process, it can help you navigate a really challenging time with hopefully a bit more confidence.
Well said. And as we wrap up this deep dive, here's something maybe to think about. The journey of healing after a major burn, it really is about so much more than just the skin, isn't it?
Oh, absolutely.
It's truly a marathon of recovery that involves incredible medical science, but also relies so much on your body's own amazing ability to rebuild and repair itself. So the thought to leave you with is, what other aspects of healing, maybe beyond the purely physical, might surprise us with their complexity and show just how deeply interconnected our physical and maybe our mental well-being truly are during recovery?